Sean and colleagues, you're very welcome. If I can ask you to make your opening statement of no more than 5 minutes, and then we'll move to questions.
Okay, thank you very much for this opportunity to address the inquiry. I have personally had the privilege of working in emergency medicine for some 25 years. During that time there's been a lot of change, both medical and non-medical, in how we approach things. If we look back to the early 90s, the idea of clinical audit and clinical governance started to grow within healthcare, and perhaps during the opportunity, I have taken an opportunity to explain how that has developed within the South Eastern Trust. People will be familiar with trolley weights and all of those things. Those actually started back in 96, 97, so it's quite some time ago that we first had trolley weights in emergency department, and the understanding around that has developed as time has passed in terms of capacity issues within the system, and that these were a symptom of a system under pressure. Government recognised the need to do something about these by introducing 4-hour and 12-hour targets, and those were largely welcomed by all the people working in emergency departments. There can be no doubt that individuals waiting for longer than 12 hours have the potential to come to harm in many ways, in terms of not timely input from the specialist, not in an appropriate environment, not in a ward-based environment, even right down to the preparedness for a major incident. So there's no doubt about that. 12-hour waits will, of course, provide a challenge to patients' dignity. So introduced in the UK in 2004, 2006, 2007, seen their introduction in Northern Ireland. I think that in the South Eastern Trust, we quickly realised that those of themselves were not about quality, or they shouldn't be the sole measure of quality, and we devised a time-sensitive diagnosis list that we would believe that we would change the outcome for if you've seen it in a timely fashion. Much as the 4-hour target has been lauded across the world in terms of way forward, there's no evidence whatsoever that it improves the outcome for individual patients. So there's no evidence of that going forward. In looking at the governance agenda, along with this here, the GMC recognised the need for enhanced appraisal, and what doctors had to do, increasingly do, as society moved away from a patriarchal acceptance the doctor knew best. Doctors had to show evidence clearly of reflective practice, and whereas there has been increased knowledge of what the right thing to do is, we have to measure ourselves that we are moving forward. There's the need for continuing change within the health service. We looked at, in the South Eastern Trust, we led the way in terms of a quality conference, All-Ireland Quality Conference in 2012, which looked not only about the 4 and 12-hour targets, but looked specifically at other things that underpin quality in an emergency department, such as left before being seen rate, unscheduled reattenders, time to triage, time to pick up those measures. Has it all been straightforward? Has it all been easy? Absolutely not. We have had to learn some difficult lessons. We had to listen to complaints that were unpalatable at times. How did this go wrong? I think, when we look at some of the human rights issues embodied in this here, in terms of our trolley weights, a challenge to dignity and privacy, of course, there, if you're waiting longer than 12 hours in an emergency department, they are. How do you manage that? How do we look after the people who are have got mental health issues? Well, we've prioritised those patients in relation to time-sensitive diagnosis. Now they're prioritised in the emergency department as best we can within the resources available. How have we looked at the care of the dying issues? These are issues that we will deal with in terms of elderly population, right to life, do not resuscitate orders. We prioritise patients who have got palliative care needs through the department as yes, there is pressures on the system for beds, but these are patients we want to get to a bed more quickly than dying in the emergency department. And the trust management have worked together on a programme, an SQE programme, in terms of safety, quality and patient experience, in order to improve the journey for patients. Not always perfect, but when it's not perfect, are we learning the lessons to reduce the likelihood of the same thing happening again? So that concludes opening submission.
Okay. Sean, thank you. And I know our questions you may want to ask colleagues to answer them, so they're addressed to you as a panel. I wonder if I could start, and it's to pick up something you said in your evidence, that while there are many positive things the Trust has done, there have been many difficult issues, and that you have had to learn from what has gone wrong. I wonder if you can tell us what those difficult issues are, what you've done to remedy them, and what are the lessons that you've learnt. And I know that's in the context of having done a particular initiative about unscheduled care. I wonder if you'd start with what were the issues that were going wrong, and then take us through how you've tried to put them right.
I think it's true to say that there's been a changing landscape of emergency care with the passage of time. I think the landscape has changed both structurally. One of the biggest challenges of recent times has been the basically keeping emergency departments open with the numbers of staff, and that has impacted across the whole region. Much will be made of the numbers of patients who in emergency medicine have remained constant, but the number of departments have actually reduced, and we have seen a significant increase in the number of patients coming to us. Medical care has developed along several ways in terms of increases in oncology, increases in the way we treat stroke, sepsis, so patients are surviving longer. So one of the big challenges for all emergency departments is the changing demographic. And that puts a challenge on the whole system in terms of the integration of primary and secondary care. Big challenge to us is at the back door of the hospital in terms of patients who are medically fit, can we discharge them back in a timely and safe fashion to the community? That was one of the challenges that the Trust has faced, has worked with commissioners to work through the TYC programme, not perfect, but working through that in terms of earlier discharge of patients to hospital, from hospital, will allow a better flow in the system. So the largest issue we face, and identified in the RQIA report as well for the region, has been about patient flow and maintaining that flow through the department. Also keeping patients safe. We have employed more consultants, and the consultant working pattern has changed significantly from when I started, when it was a 9 to 5 job, to now consultants on the shop floor, expected to be on the shop floor from 8 o'clock in the morning to at least 10 o'clock at night. So those are some of the challenges we faced in terms of workflow, and also I think managing patient expectation. You know, the Trust has a number of initiatives in terms of measuring patient experience, what patients wanted to get out of it, and my colleagues will address some of those issues.
For us as senior nurse within the department, we're very aware of the need for the patients and the users of our service to tell us what their experience was, and we have developed a number of initiatives over the past couple of years that give us that information. And quite often then we use that information, break it down into trends and themes, and some of them are actually quite simply resolved, and other will take much more resources. For example, in a busy emergency department at the Ulster Hospital, we didn't have a housekeeper, and some of the feedback we received from users was, you know, that we didn't have enough stock or stores of pillows or blankets. I really wanted a cup of tea. The smaller detail, but it made a huge difference to the patient's experience. So we have appointed 2 housekeepers who work across the 7-day service. They don't provide hands-on clinical care, but they're there making sure that the environment is safe. They have got the time to do the cup of tea when it's required, and have made an absolutely fantastic improvement in the patient experience, but not only for the patient, also for the nurses on the floor, because when they go to the cupboard to get the bit of kit that they need, it's stocked and already there. So simple changes makes quite often such big improvements.
Okay, can I just ask you, you said there were trends and themes from the feedback you got from patients. I mean, can you tell us a bit more about what those trends or the themes were? Obviously the housekeeping one's an important one. What were the other things that...
There are, for me, when I look back on it, there are a few. One would be re-evaluation of pain relief, timely administration of pain relief and re-evaluation. Another issue that we would like to progress is also the management of, or better management of, children within the department. We're seeing issues coming through also with regards attitudes and behaviours of nursing staff and medical staff, and those are obviously very important that we hear that and we do something about it. The environment was a good learning point for us, and communication, making sure that the patients and relatives have the right information at the right time. So those would be themes that we would work through. A lot of those more recently came out of our 10,000 Voices report, which we participated in the regional project. We're very pleased to say that South Eastern Trust had the highest number of respondents. We've looked at the feedback. Those are the five key things that we're now taking through to staff. And between now and December, we've set up a series of 4 workshops with staff involving security, portering, domestic services, our nursing auxiliaries, our senior nurses, our junior nurses, and our medical staff, AHPs. 4 different workshops where we can say, guys, this is the feedback we got. It's not always resource implications with it. As I've said, some of the solutions will be very simple and straightforward, and we look forward now to building an action plan to help improve that, for the service to come over the winter.
Okay, thanks. And one final question on this, and then I'll maybe just, Jill, ask you whether you want to comment on it. You've said that not all the things that need dealing with are about resources. Are there any things that have come through to you which do have resource implications that you haven't been able to tackle in the way that you would like, simply because there isn't the funding there?
I think the flow of the patients actually through the department to a timely placement in an appropriate ward, that there is certainly a resource implication there. But that has an impact on the care that can be provided within the department of the patients that are waiting for beds as such, as well as workload coming through the doors, the regular A&E workload as well. So there, from a staff point of view, there certainly would be, it's increased workload on staff. There'd be increased workload on staff, and there would be increased pressure on staff to provide a high standard of care in what is essentially not an environment, a ward environment for those patients who are waiting for beds. So certainly it would have a staffing implication.
If I could take that just one step further, for example, the 7-day working of the whole system approach. I was on call over the weekend and because there isn't always that full participation of 7-day working and commitment by everybody across the entire spectrum of the service, I clearly could see that there were issues at the back door of the hospital that had a ripple effect, and whilst they were resolved not in as timely a manner as I'd have wished, but they had a ripple effect to the impact of the service of the patient coming through the front door, and a slightly delayed length of time in the department.
I think also what I would say is that there would be many within the specialty who regard unscheduled care as being the poor cousin of elective care in terms of investment and resource, and looking at that going forward. I start a ward round on a weekend morning, and as appointed as a consultant, I'm still doing some of the things I did 25 years ago as a houseman, whereas I don't believe other specialties would be doing that, where a consultant would be doing the discharge letter, handwriting the discharge letter, writing the prescriptions, doing all of that sort of task that would normally be a junior doctor. So it's very tangible. There's been very tangible issues with regard to resourcing of unscheduled care, and it hasn't, had the political emphasis until relatively recently that other non-unscheduled care or elective targets have had.
Yeah. Okay, can I turn to, before I move to comments, I wanted to look at the issue of serious adverse incidents, and I think my starting point is to get a sense of how they actually work. I mean, we'll come to the learning, but how does a serious adverse incident get identified in the first place? Who identifies it? How does it get activated? And I wonder if you can just take me through that so I can understand a bit better the process.
So we put in place some years ago a recognition of a system that needs to recognise these at early stages. And that came about from learning from a complaint that, quite frankly, I was not aware of as a clinical director. And so therefore we have a system of unscheduled reattenders. We look at those in terms of if they come back unscheduled, has something gone wrong. And we look at untoward incidents that we are made aware of in terms of outcomes of, we look specifically at people who die in the first 24 hours after passing through the emergency department. So we look, there's a variety of sources we can come in. Clearly if somebody's come in the morning being discharged home and comes back in a near-death situation, then clearly we need to investigate that to see, was this predictable? What was the learning? Was there something missed in the initial assessment? Then through the case will be discussed with myself as clinical director and then the governance systems within the hospital and managers, senior managers, to highlight that there's something that needs further workup and explanation to that. Obviously the department decision will be made, does this meet the criteria of a serious adverse incident? And is there learning that we have to put in place? It will fall into three levels. Individual learning, which is linked to good medical practice, and revalidation, is the reflective learning for the individual involved. Is there departmental level? Because many of these things will perhaps be systems that are not in place or new information. And then is there a wider regional learning piece from it? And, medicine is evolving, the challenges are changing. There truly is new learning, and some of these will reveal new learning, new thinking. Some of them will be, why did that happen? What was the system in place? Was there not learning? Was it perhaps the junior doctor not trained sufficiently? Was he or she left exposed in a situation that their skill set was out with what was coming through? And this is one of the challenges, one of the broader challenges when people, see that 25 years ago it was perfectly acceptable for a junior doctor or maybe two junior doctors to be working overnight with no middle grade doctor and a consultant at the end of a phone. Now that's not acceptable. It's quite clearly not acceptable. We need to have more middle grade doctors. But that's put emphasis on things. And we have to be very clear that where the responsibilities of the emergency department, people will talk about ED and the emergency department. Sometimes it becomes everybody's default position that we're coming in and dealing with, emergencies that perhaps not ours to deal with, or clinical urgencies that are not ours. I was asked last week by one of our team, how was my paediatric dermatology? Well, I'm not a paediatrician nor a dermatologist. We do need access to people accessing emergency care in that setting. So, outlining the increased awareness, an open culture in the organisation about that, and the learning culture helps that process move forward. And they're not to be feared; they're actually to be learned from. And the responsibility is actually to limit the opportunity for this to happen again.
Okay, can I just get my head around this? The serious adverse incident, if something happens, you look at it, is it a decision of yours, Sean, as the clinical director, or this needs to become a serious adverse incident as opposed to something else? Or does that go to management, or is that a joint decision?
It's largely a joint decision, but sometimes, the issue will perhaps be this is an untoward event, this is an unexpected outcome, this is, will come down to, as a collective, we meet as a group of consultants once a month to go through untoward incidents. Clearly we'll meet more frequently than that if there's something very emergent, but we look through these here, and as a collective, as a part of a team, we will come, our decision will be based on what we think from the best evidence available, and in discussion with management, open and honest discussion with management, do we think this is something that there is actually learning from and merits going through the serious adverse incident process.
These reviews not only involve medical staff but also nursing staff, and nursing staff are involved from the onset, from the initial period. And it's not just the nursing staff involved in the incident. That information and the learning is shared throughout the team and across the team, both medical and nursing. And that can be done either at staff meetings or through our safety briefs. We have twice daily safety briefs. So any learning from the adverse incidents that we have would be brought up and highlighted at those safety briefs, and any recommendations made then put into practice. So all staff are included and involved in that process.
Mm-hmm. Final question then from me, which is, if there were two things that you would, to each of you as individuals, that you'd like to see happen that would make a real difference in the service, what would they be?
From a shop floor point of view, from a management point of view, on the shop floor, certainly improved flow throughout the hospital, not just through the department. We have our 4-hour targets and our 12-hour breach targets, but I think sometimes, from the patient is quite quickly assessed at the point of triage, and we have time-sensitive diagnosis, and we've also in place pick-up time from the time of arrival to pick-up time of 1 hour that the patient, the initial assessment will start at that stage. Where we find the difficulties are where the decision to admit for a patient has been made, but there's a block then in the flow throughout the hospital for that patient being placed in an appropriate area that can best meet their needs, in a timely fashion. So that, from a nursing point of view, would greatly improve the patient experience and also the staff experience as well within the department. Something that would be more easily rectified and improved would be in and around our pain management of patients, and that's pain assessment at triage, use of PGDs, so that the patient is given appropriate pain relief at the initial point of contact, and then pain reassessment. It's no good in giving pain relief if you're not going to go back and reassess, and we have plans in place to review those procedures currently.
Okay. And can I just get what the difficulty has been with that?
I suppose the difficulty I suppose was identifying the issue initially, and then putting in place a process as to how we would assess and then reassess, reassess the patient as well.
Okay, yeah. Sean, your two two wishes?
One wishes. One, very much concur with the clinical path, clinical flow through the emergency department, and emphasis of that. All of those things that Jill has said. I suppose from a wider system perspective, I would like to, I'd like us to move on from, politically, from a situation that there seems to be the mantra of no change to frontline services. Frontline services have been changing and evolving with the passage of time, and this, what we hold approach, and it's not necessarily a good place to be, given the realities of finances in Northern Ireland and in the Western economies as a whole. So I think we need to move on from have a debate about what is outcome driven. What can improve the outcomes for patients, bearing in mind the rights of patients, and paramount to that, of course, human rights of patients. What is the best out? How can we deliver the best outcomes within a financial envelope?
Okay, thank you. And Ruth?
Okay, I've touched on this because I do feel quite passionate about it, and it is about improving the patient experience. And we have the tagline within the trust, that we get it right every time, but unfortunately there are occasions when we don't get it right, and it's about learning from those. And as I've said before, not everything is resource dependent. Mm-hmm. And the simple attitudes and behaviours. We're planning now to adopt the initiative of Hello, My Name Is, because absolutely key to all of this is staff meeting and greeting the patient from the first point of contact is when the first impression is created. So those first matter of seconds within the department can impact very significantly on whether the patient coming through and their relative whether they have a good or a bad experience. So, thank you.
Okay. Marion, do you want to
Good afternoon.
ask?
I have 5 questions. It seems enough on the mind, but anyway. And again, whichever panel member wishes to answer them, they relate to participation, dignity in death, meeting the needs of particular groups in A&E, and then staffing issues. In terms of participation, are you content with how information on treatment and likely risks to survival are shared with patients and carers by junior and middle grade staff? And what steps are you taking to address any shortcomings that you may have identified?
I think the reality of it is emergency medicine has been set up to evolve for resuscitation practice. We do deal in unexpected death. You know, there would be approximately 5 patients per month will die in the emergency department of the Ulster Hospital. Many of these, not all of them, are as a result of a natural process or perhaps trauma being included in that as well. So there is that sudden death element to it. There is, as time has went by, the risks, people are more apparent in the risks in terms of what good medical practice is, that the patient is fully informed of things. We do audit what the patients are told in terms of the four tenets of good medical practice. Is 1, you should inform the patient of the diagnosis. 2, you should give them the red flag symptoms to look out for in terms of what might be harmful to them. 3, you discuss the medication with them, and 4, you discuss what the review. So we do audit that in terms of what they're told. Some of this will be very challenging. 1/4 of all cancers are diagnosed in emergency departments now. We're not going to know the prognosis in that case. We know it is about breaking bad news, so it's not possible for us to know what the prognosis is going to be, or even the treatment pathway. So we have to be honest about the diagnosis. We have to be honest about, in terms of those who come in dying, you know, at the end stage of a chronic illness, and then we have to be honest about whether that is the right place to actually for the patient to die. We have a policy in place that if we identify that we fast track that patient to the ward quickly, so that they don't die in a busy emergency department. Because if you were dealing with, as we do, 240 patients a day on average, then unfortunately the next patient's needs will overtake the needs of the relatives. So therefore, it's not the best place to die, and we try to expedite the patient to the ward in a timely fashion. So yes, there are lessons around it. Yes, there's the sharing of information. Yes, I can remember very clearly where we've got it wrong, where we didn't recognise the symptom complex as being a terminal event. You know, that we didn't recognise that as being a terminal event, because in normal cases not, but we didn't have the information, and we don't always have the information from our palliative care colleagues as to what is going on. And palliative care doesn't always mean to a number of people, or have been explained well enough, that means on, you know, potentially a care of the dying pathway.
In terms of clinical staff being involved in planning to improve on such scheduled care, could you outline what steps are taken to include clinicians, and have you any suggestions to take that further?
Well, I think clinical staff, if initiatives in terms of unscheduled care are taken forward, you know, in terms of if it's resource driven and it's taken forward through the system, I would meet with managers in the organisation, and we'll put forward a case for development of it. It would be, the trust has adopted an approach. Well, if you think this is going to work, we're going to trial it and see if it does work, and there will be a trial put forward of, you know, for a short period of time or whatever period of time is appropriate to ensure that it does work. And if it then works, then the trust will take it forward with the commissioners, you know, to bring forward the suggestions, and we have examples of that over the past that have led to enhanced number of consultants working in the department. We're held to account by the fact that it's not, you know, this is something we all did for a month, but now we've given that idea up. We're not going to get away with that. So I think the funding of unscheduled care has not have attracted the same attention as the funding of elective care, and that's been as a global issue for the organisations.
Quite often staff, junior staff nurses and more senior staff nurses, well, we would have our weekly team meetings and our professional meetings, but very often they can come up with initiatives or improvements that, as I said, are not resource dependent. For example, we have an ambulance triage nurse now, so that assesses the patients coming in via the ambulance route in a much more timely manner. Another initiative or improvement that staff came up with directly themselves was someone, what we would refer to as a tracker within the department, and they would work alongside the doctors, giving them the heads up when blood results and things like that are back through, so making sure that the experience and the timeliness of everything is without fault then.
Can I turn to dignity and Downe? You've already touched on it, Sean, a couple of times, in that you have a very busy department, 240 people a day. Is there any suggestions that you could make that would alter the experience of people who enter and you know very soon that they're going to die, so they're given the dignity that they require within emergency care?
I think, I think one of the things that has helped us along the way is more information. You know, we get a patient who's very unwell. They may come in from a nursing home, they may be unaccompanied. What has happened is that we now have information technology such that we can, through their clinical care record, we can look up what has been going on in the past with them quickly, and that will dedicate decisions regarding their initial treatment, because there is a tendency, if somebody comes in with a treatable condition, to immediately go to get the treatment out and go, especially if you're working in an information vacuum, which we on occasions are, to be quite frank. Whereas, you know, getting more information, I think having advanced directives, you know, in place that are fully understood. I think also there's a large body of work to be done in some of these cases with the family that, you know, I can see very clearly and remember very clearly somebody coming in the last year or so dying within 15 minutes of arriving, and the family being very upset by the fact that we're being brought from a nursing home that had been present in for 12 years to the emergency department, when it was quite clearly half the family went to the nursing home thinking they were going to spend the last minutes to find it being transported here. So there is work be going on around that. I do think that we have upgraded the relatives room recently so there's provides a better structured environment for breaking of bad news. We would like to get an enhanced body viewing area. Would be all things that, you know, we would like to get post, and we do attempt to do that, you know, in a quieter area of the department. So those are things that would bring better outcome for relatives, and we're very clear that we do try to expedite as all possible, even in times of great pressure. We prioritise patients who are likely to die in the coming hours to a bed, because that's a better environment, ward-based environment. It's a better place to die than in an emergency department, which is naturally unpredictable and busy.
You know, the care of the individual coming into the department, we will place them in an appropriate cubicle, and we will involve the family at all times. Now, if that includes the family wishing to be there with their loved one during the resuscitation process, we will facilitate that within the department, and we will always have a nurse that will work, you know, alongside them and be the link between the family and the clinicians. We'll also allow, if the patient does die in the department, we will allow whatever period of time the family really need to spend with that individual as well. You know, it's not a case of, oh, right, okay, with somebody else coming in, we need to move you on. The families will be given, you know, the support and the encouragement to stay with their loved one as long as they feel they need to.
Thank you. Moving on to particular client groups, you know, children, patients with mental health problems, elderly people with Alzheimer's, or people with pre-existing brain injuries. Can you identify the challenges dealing with the particular needs of those groups of patients in emergency care departments? And have you any suggestions how you could improve that experience?
We have a number of vulnerable, sectors of the community that use our services. With regards to patients coming in who have dementia, we are currently using the butterfly scheme, and it's an identification factor. That staff are made aware that a patient who has come into the department has dementia, so that their care needs are tailored to meet them. They will be placed in an appropriate place within the department where they can be seen and observed, and staff are allocated on a daily basis to particular areas, so there will be a staff member that will be allocated to their care. As regards children, there have been a number of initiatives that have been ongoing. We would get a lot of our feedback and development of initiatives through user feedback, whether that's through our patient and client standards or through the 10,000 Voices initiative. One of the areas would have been paediatrics and children within the emergency department. And again, there have been a number of developments that have come out of that. There's more timely access, certainly Monday to Friday, to the paediatric rapid response clinic. And we also have interface meetings with our paediatric colleagues, and that's on a monthly basis, and that's to discuss issues that there are that the emergency department face, and also issues that paediatrics have identified that can be improved upon within the emergency department.
For example, then even with learning disability clients, we've done a significant amount of work over the past number of years and developed the health passport, which I think is a fantastic tool. I'm sure you know that there's a core amount of information is available that when the learning disability client arrives within the department. It's key information about medication, contact details, likes and dislikes, and all of those things will influence. If we get it right, they will much better influence patient experience. And then we continue to work with our learning disability colleagues and meet with them on a quarterly basis, and we look back to see if there were any incidents or attendances that we could have learned and done better with, or how do we take this to the next stage. And it's about creating, whilst there would, at that early project, there was a baseline awareness of learning disability for all nursing staff across the 3 sites. But the next step up will be about creating that champions who will have that wee bit more expert knowledge. So it's a continual cycle of review and working in partnership. We do the same with mental health. We developed the self-harm pathway, and that's commenced at triage. So it's an early risk identification, and puts the needs of the patient first.
I think there's an example of learning across the organisation, because we had a complaint about 7 years ago from a relative of a self-harm patient who felt that their loved one had been discriminated against by the time they waited to be seen by a doctor. And I researched this, found that mental health patients did on average wait longer than ordinary patients, and that average waiting time to pick up, they were slightly longer. I questioned this. I didn't think that was right. So what we did was positively discriminate, and that they are at a higher triage category, so that they are seen. We reversed the trend that mental health patients are seen before the average patient in the department, and that was controversial at the time, but it has been effective in bringing it forward. We've been that in place across all 3 departments over the last 6-7 years. That mental health patients are positively discriminated for, and that they're seen in a more timely fashion. I mean, this allows both the triple assessment of these patients, both in terms of medical need, mental health need, and risk of absconding or leaving, are assessed.
My final question, you'll be pleased to know, is it relates to staffing, and I'm wondering, could you outline the skills mix in your emergency care departments? Have you any suggestions to improve that, or have you any concerns about it? And it would also be helpful to know what staff support and training opportunities are available for clinical staff, nursing and medical in EDs.
I suppose I'll address the medical, and my colleagues will address the nursing. I think that emergency departments, by their very nature, are stressful environments. People have concerns about work-life balance and getting it right. I have two examples very, very personal to me in terms of after spending a long weekend working in an emergency department with what I regard as a very good registrar. She turned around and said to me, "Thank you, Mr. McGovern, that was great, but you do know that I don't want to do what you're doing now at 50 years of age." So it was actually a turn off, and that's why there's been people turned off by the fact that it has been very much out of hours. So the numbers coming into the specialty, and we'll need to balance this here. We're setting higher standards. We want consultants to be present 16 hours a day, 7 days a week. Well, we need the correct number of consultants to do that, and I don't believe we have achieved that currently. If we do that, then ultimately we'll attract people into the specialty, because we have suffered in attracting, recruiting people. My son, who's interested in medicine, asked me recently, did I fail my exams to be a general practitioner? He asked his mother that the dad failed the exams to be a general practitioner because he was aware that they didn't quite have to do the out of hours that not all GPs had to do the out of hours that were expected in emergency care. So there are real challenges across the piece. There have been well documented challenges to emergency departments in terms of having the correct number of staff, and no later than I think the president of the college, Cliff Mann, give evidence last Friday that the recruitment and issues would probably take about 6 years to work their way through the system. So that's not going to go away quickly, and that's why there will be stresses and strains on recruitment into emergency medicine at this juncture.
From a nursing point of view, some of the difficulties up until really this point in time was that there wasn't really a regionally recognised tool that we could benchmark our nursing staffing levels against. But more recently, there's been the development of the BEST tool, which not only looks at numbers coming through the door but also acuity. So we welcome that opportunity for nursing within the emergency department world. At an operational level, across SE Trust, we use eRoster, and that allows us to benchmark, set our skill mix and our skill set. So not only would we have indicators of how many we would need on per shift, but with also the skill set of those nurses. It advances the roster over a 4-week period, and then it'll be able to tell you where the gaps are so that you can forward plan in advance and recruit into those vacant posts or vacant shifts. I'm very happy to say that, and with confidence, that across South Eastern Trust and the Emergency Department nursing workforce, there are no significant issues with regards to recruitment and retention. I think workforce are very happy. I think they feel supported, and it's supported from an education point of view. They get lots of training opportunities. We've talked about mandatory training within the trust, and then we have the skill set of mandatory training for the emergency nurse. And that once they have those skills and competencies, it gives them the confidence to do their job. Maybe Jill, you want to talk about some of the ongoing training initiatives that we're...
I suppose first and foremost we have an open door policy. As a clinical manager within the department, it is a case of we will encourage staff to come with any concerns or raise any issues that they have, and essentially that's any time, day or night. We also encourage them to report concerns. We involve them in all areas of change, the change process within the departments, particularly in and around the change in hours for Lagan Valley and Downpatrick. Staff were involved and informed, and there were regular roadshows that staff could avail of to get information, and I suppose it also allowed them to ask questions as well in and around the service. We also have as Ruth has said, quite a lot of education, and there is work ongoing at the moment with both the RCN and NIPEC and the emergency departments, looking at workforce planning and also career development for emergency care. And I think that has probably been a long time coming, and it will improve staff morale whenever they have a career pathway to follow. We also have regular appraisals and supervision, and staff will have an appraisal done once a year, and that identifies both, I suppose, changes that the department and the trust require of staff, but also what staff feel that they require as well. So it's an opportunity for staff to ask, for training and further development for themselves. So there are a number of avenues that staff can, come and either raise concerns or ask about what things that are particular to them as well.
Okay, thank you very much.
Over to Paul.
Thank you, Les, and thanks again for your time this afternoon. I understand that emergency care it's incredibly complex, and I'm also very conscious of the fantastic work that is done by a large number of really dedicated health professionals. So that's very much in my mind, and it seems to me that a good health professional is actually a good human rights worker. There's a lot of alignment between the principles and objectives of health professionals and the principles and objectives of human rights. However, we know that sometimes things have gone wrong, and what we're trying to do is sort of apply a human rights lens to ED to see what it demonstrates, what it shows. Some of my questions are about governance issues, and you've already alluded to a number of these. Some of my questions are about governance issues. I mean, why? One reason is because governance is a critical part of a human rights-based approach. Secondly, why governance? Because there's been some suggestion that the health system and emergency care in Northern Ireland is or has been quite top-down, not sort of very participatory. And that, from a human rights point of view, that's a bit problematic. From a human rights point of view, one wants to try to make it as bottom-up as possible. There are limits to that, but as participatory as possible, including participation of health professionals and the public and patients and their families. Tricky, I know, but that's one sort of human rights principle, to get as much participation as possible. So hence some of my questions about governance. Now, you've commented on the first one already, and I want to make sure that I've understood it properly. I'd be grateful if you commented on the degree to which you're involved. For instance, are you consulted in the commissioning process with the board? And you did allude to this some half an hour ago, but I'm interested in knowing to what degree. Presently, the usual practices about whether or not you're being consulted in, you as health professionals at the coalface, whether you're being consulted in a sort of systematic way in the commissioning process concerning emergency care with the board.
I think it's true to say that we're in a better place now in terms of the need for healthcare professionals to be engaged in commissioning has been highlighted by a number of College of Emergency Medicine reports. Understanding what was in process prior to this is very key. We had a good relationship with management, and as I explained, we went through an internal process to justify what we needed. We understand our data. We understand our data better. If you're going to make a case, you've got to understand your data in terms of what is your commissioning. We are being listened to. I think there is an awakening at board commissioning board level that there needs to be more input into emergency care, unscheduled care, and that professionals who are working in the area are well placed to give advice regarding this here. It all has to be, it has to stand up. You know, it can't be a wants-based approach. You know, I want. It has to be a needs-based approach. And that we all have to be sophisticated enough to realise that healthcare is changing. It needs to change. We need to be patient-focused, outcome-driven, and have an understanding of the fiscal pressures. That is not a blank sheet. So I do think that moving forward, the College of Emergency Medicine is involved, and professionals, both in medical and nursing, will be more involved, and the development of, Ruth has spoken about the development of a tool. What is the best tool to commission a service around? So those are tangible things that are happening that perhaps in the not too distant past weren't there. You know, and others. Emergency medicine has been, you know, everybody's, you know, it's a bit like, you know, people work in many doctors have worked in emergency departments, and they tend to reflect upon how it was 20 years ago. Well, that's about like I've been on a flight, so I know how now I know how to land it. You know, you've only travelled on the flight. You don't doesn't mean you know how to land it. And that's the same way for people who've passed through emergency departments, give their view about how things should be commissioned without actually, in the past, having any sort of detailed understanding of their issues.
So, Sean, I think it's clear that you have been involved in the commissioning process. So I'd be interested to know, I mean, there's no right or wrong answer. I'm just trying to understand the reality, right? I mean, Ruth and Jill, whether or not...
The organisation works in such a way that there are clear lines of communication.
Right.
And, you know, opportunities for me through to the Director of Nursing, through the, you know, to Director of Acute Services. Right. If there's a service need, you know, those pathways we can table and chair, and as Sean says, right, put forward the case or the need for additional service.
Jill?
I would tend to agree with Ruth. You know, the management process is there, and, you know, we can influence to a certain degree what services from a nursing point of view that we feel that would be beneficial to our patients, essentially, such as our EMP service or advanced nurse practitioners.
Yes. And
that can be taken through, as I say, through management.
Okay, thank you. And just to continue with the sort of governance question, in the Emergency Care Summit of May of this year, there are these really interesting slides about the South Eastern Health and Social Care Trust, and there's a reference to turnaround overview and some new governance structures. And I don't know if any of you wish to comment on any of them. One is an improvement board meeting monthly. Another is steering group meeting fortnightly. Also, a critical friend to advise on best practice. And I mean, there's lots here, and I'll just mention one other for now. Identifying opportunities to improve collaboration between hospital and community care, which I thought was kind of interesting. So there's quite a lot I've just mentioned, and I don't know if any of you wish to comment on that. You've already alluded to some of these things. You've already alluded to them. But I am interested in new governance, even if they're a bit experimental, that's fine. But I'm interested in new governance structures that might be somewhat experimental to try and open up the governance in your hospital.
Yeah, well, I think the turnaround team was put in place to relook at the things we're doing in terms of improved patient flow. It actually focused on attention to detail regarding the things we're doing. It focused on the timely discharge of patients from hospital. Critical friend ideas is, you know, we look at our practice, and somebody else comes along and looks at it perhaps in a slightly different way. Is it, you know, are we as an organisation open to change, and are we capable of delivering change? Yes, we have delivered change in terms of there's been significant improvement in the 12-hour breach situation, and that means calling people to account in a different way, and a different way of working. And also, when we start something new, it's very important, and one of the things that the organisation does is that when we start something new, we've got to realise the the unexpected, untoward effects it may have on something else. So that better understanding of the various bits of the organisation, how they work and how they impact, and the whole system. We're an integrated healthcare system here, and therefore it shouldn't be a surprise that the hospital and community are working together. But we build on that relationship, and when times are difficult, there can become a natural tension between whose fault is it anyway.
Sean, are you on the improvement board? Yeah. Yeah. And this, the critical friend, is this I don't quite, I mean, I understand the concept, but is that a particular person? How does this work, the critical friend work?
Well, there's an external organisation, ALAMAC, have been in place, and
yes.
so they have been asking questions, about why things are done, or the accepted norms, can we move things forward in a better way, and also we're coming together of, managers asking why this is done that way. Can it be done in different ways? Can we have different ways of looking at it?
So the critical friend is ALAMAC, really?
Yeah, critical friend is ALAMAC, and also, but also having that culture in the organisation, embedding that culture in the organisation, that we question what we're doing, and is that the best?
Right.
Yes, John, is that the best way forward?
And who else is on the improvement board? I mean, what does this improvement board consist of? Who does it consist of? I'm not trying to trip anybody up. It sounds rather interesting, and I'd like to learn about it.
It's led by there's managerial input from across the critical areas, which is medicine, director of hospital services, so it's senior management and senior clinicians in this working together for the goal of improving patient flow through the department, through the hospital basically.
And are there minutes? I'm not saying there should be, I'm just interested. Are there minutes
Yes.
of the meeting?
Yeah, AHP involvement and both rep from both acute and community.
Right. And if a member of staff wishes to go, they can go? They're open meetings, or is it just invited people? Again, I'm not saying they should be open, I'm just trying to find out what this
I
is.
think there've been a combination of there've been road shows around the improvement, so they tend to be smaller meetings. Not everybody will be able to go, but so there'll be the improvement board. Elements of those will meet with individuals to improve things, and there's a combination of open and closed.
Okay. And I mean, you're not obliged to, but I'm interested to learn more about the. You're not obliged to share it, but I'm interested to hear more about the improving collaboration between hospital and community and primary care. How is that being actioned yet, or is that something for the future?
No, there's clear evidence of improved working. We have a situation where patients in hospital, what the system can't afford is patients who are medically fit remaining in hospital while there's a community package being got. Mm-hmm. So therefore there has to be an enhancement. What is it that's going to improve in the community? We're actively looking at, we've visited Sheffield, we're actively looking at a discharge to assess, where patients are discharged to the community to be assessed as opposed to having all the assessments based in hospital. So there are a number of initiatives which cross both the hospital and community, and are moving forward on those.
And Sean, you mentioned ALAMAC. I'm not quite clear what ALAMAC is. I know it's a critical friend. and I'm looking at these slides from the summit of a few months ago, so I learned a bit from that. But could you explain who or what ALAMAC is? And I understand... yes, please.
They have been an external consultancy company who have experience in managing unscheduled care issues across England. They've come into the organisation, harness much of the good ideas that were there already.
Yeah, sure.
That and bring a newfound attention to that. Many of the principles, we were familiar with, but packaging them together, they focus on it is attention to detail, and they focus on what looks good. Why was it good that day, and what was done that day, and why? And they set targets that perhaps weren't there before, in the sense of the number of discharges per day that we need to have from the hospital to make the flow go better. And I think the trust management have worked with clinical staff in a whole engagement exercise of, can we move the thing forward in a positive way.
So in this slide show, it says they provide some independence and they help to drive cultural change. They assist the teams to be accountable to one another, that sort of thing.
Yeah.
It's a quite a complex, but at the same time very integrated approach. I sit on the conference call every morning, and as Sean says, there are a number of standards of good practice there, and we benchmark ourselves on those. And when you put all the pieces of the jigsaw together, then we can predict activity within the hospital, and we can recognise at an early time if we are going to face pressures that we need to do something different. You know, for example, I'm there, there'll be a member of ED staff on the call as well, there'll be a rep from surgery, social work, inpatient medical beds rep there as well. And together we do a partnership approach, a whole system approach to help address some of the challenges that we face within emergency medicine every day of the week.
Mm. And did you say it's a telephone conference call?
Conference call.
So where are Alamac?
They're based in England,
right.
And then on the early start of the initiative, they would have met with us on a weekly basis. They gave us the skills and the tools and the techniques that we need to do to manage this on a day in, day out basis, and we maintain regular sort of monthly contact with them.
And you'd recommend some arrangement like this to other trusts, would you?
It looks at a whole system approach, so it has been very, very beneficial. As Sean says, last year, April time, we had 282 12-hour breaches. In May of this year,
it's gone down.
We had one.
Yeah. No, the data. I've seen the data. It's encouraging.
Yes.
So you would recommend it to others.
Some of the other trusts now in the province have adopted this Alamac solution as well.
And I'm out of time, so I'm going to confine myself to one more question, if I may, Les. Is that okay?
Yeah.
Thank you. I'm trying to understand and genuinely interested in your view about whether or not, maybe you'll tell me it already happens, whether or not if there isn't, there could be some mechanism within the hospital, that permits the public to have a say, engages the public. I don't mean anyone walking in off the street. It would have to be somehow institutionalized. So in the same way as Alamac provides a degree of independence, helps to drive cultural change, assists teams to be accountable to one another, I mean, is there an existing, or perhaps you'll tell me there's already existing mechanism by which the public can just give their view about what is happening, what's going on, what would be useful, successes, shortcomings, that sort of thing. I don't mean taking complaints, that's different. I just mean being able to articulate a sort of community view of what would be, what's working and what isn't working. So I suppose, first of all, does that already exist? And if not, frankly speaking, do you think this is doable, or is this just a sort of a very romantic view of participation?
There are processes already in place that look at that. The 10,000 Voices project is ongoing. We were one of the pilot trusts to take that initiative on, and that is ongoing within the South Eastern Trust, so there is still feedback coming back to us. Those patient stories were actually very powerful, and we did present alongside the regional lead for the 10,000 Voices scheme as to how it had impacted on emergency care and changes that we had actually improved upon. And we've already talked about a couple of those in and around our paediatric interface meetings and better access to the rapid response team for PAEDS. Also within the patient and client standards, that information is ongoing. We undertake our own clinical observations within the clinical area. And we have done a number of patient stories within each of the three emergency departments, and also within the MAU in the Ulster, to look at what matters to patients, what was good for them and what wasn't good. And we have looked at putting in place initiatives to help improve that again in and around.
Whilst some of those processes are quite structured and have a series of questions, you know, the ability to, the patient stories themselves allows whoever's taking the story that opportunity to sit at the patient bedside and hear the story without, you know, pre-existing questions or a focus to it. It's, you know, what is your experience from start to finish? So it's an open landscape, a free landscape. So that gives us very valuable information.
Okay, thank you very much.
Okay, we'll wrap it up there. As I've said to everyone who's given evidence, we're more than happy to take written submissions on anything that we've asked about or anything that you want to alert us to. So feel free to do that. And it just remains for me to thank you very much, all three of you, for your very detailed answers and your evidence. So thank you very much indeed.